Thank you, Dr. Uthman. Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. First of all, congratulations for the four association for this joint meeting for the second time. Thank you, Dr. Ahmad Ibsi, for this kind invitation and the whole group. This paper, actually, we have presented in the last ASH 2023, and I am going to represent it here again. Before I go ahead, I would like to acknowledge my colleagues in this study. You don't need probably to know about Medina and the geography and so on, but probably you need to know that Medina population, it is 2 million plus. 1/3 of them, they are expat, and most of the expats, as all other places in Saudi Arabia, they are singles, and they are selected, so they don't have major disorder or chronic disorders. 4 years ago, the Medina Hemophilia Comprehensive Care Center, it was one center, and currently it has been divided into children and adult side. Starting, I think, from last year, we are dividing the adult even further into 2 sections. So we have 3 sections for the Medina Comprehensive Care. You are aware about the coagulation issue and the cascade, but in Glasman thrombasthenia, we have problem with the platelet aggregation where the where the glycoprotein 2B3A is not functioning very well, or it is deficient enough that the attachment of each platelet to the other platelet is deficient in those patients. And it has been classified into type 1, which is severe deficiency, and type 2, which is milder deficiency, and variant GT, where it is not very well understood whether it is functional or other issues. Some of them, they have normal glycoprotein on flow cytometry or deficient, and we do not know about the function very well. Glasman thrombasthenia, it is, sorry, it's rare, considered rare bleeding disorder elsewhere in the world, where the incidence it is 1 in a million in the Western countries. The matter is different when we consider the Middle East, where you can appreciate that it is in the east of the Middle East, it is a common bleeding disorder rather than rare, where the prevalence in Iran in 2004, it has been published as the 1 in 200,000. 5 or 6 years ago in the Gulf, Arabian Gulf countries, we have reported 1 in 190,000 of the population. The west of the Middle East, except for Tunisia, they have reported low, and in the Western country, it is low. In Europe, they have 200, I think 260 or 260 plus cases in the whole Europe. Look at the consanguinity rate among the countries in the region. So comparing to the Western countries, the Arabian Gulf countries, the consanguinity rate is very high. And probably those genetic disorder, which is autosomal recessive, is high among our nations, not only the Glasman thrombasthenia. To diagnose Glasman thrombasthenia, it is not very difficult. Probably the flow cytometry is enough to diagnose it after you do the bleeding score, the screening test. Usually we don't go for the platelet aggregation. It is more difficult and more expensive than the flow cytometry. And most of the time we don't need to go for molecular diagnosis, except for specific cases where the diagnosis is a bit difficult, particularly the variant Glasman thrombasthenia variant Glasman thrombosthenia. This is the modality of treatment, which is mainly controlling the bleeding, but the curative treatment is stem cell transplantation. People are working on gene therapy currently, and two companies, they are working on the prophylactic medication for Glasman thrombosthenia. One of them is nearby to be FDA approved. The other one is still under phase 1. So what we have done, it is a registry. It is about 25 years old, and we cut off this time to the 20 years. For those patients whom they have confirmed diagnosis of Glasman thrombosthenia, and we define that they have flow cytometry or molecular genetic conclude the diagnosis for those patients. In the registry, there is 136 patients, and this is all data, by the way. It is 1 year old data. Over the last year, 2023, we have added probably 15 or 16 more cases. Since I have presented this paper to ASH 2 months ago, till now we have added about 5 more cases. 125 included in this study, as we have full data, or more than 70% of the data we need are available, and we excluded 10 patients where we don't have enough data for those patients. Make the prevalence of Glasman thrombosthenia in Medina 1 in 10,000, which is more common than hemophilia. As other results, as other publication, it is more predominant in female a little bit. And almost all of our patients, they are Saudi but one. And at the cutoff of the study, most of our patients, they are 5 to 30 years of age, but most of them, they present before the age of 5, and 1/3 of them, they have presented before the age of 1 year. Probably this is related that they have family member whom they have Glasman thrombosthenia, so whenever there is a newborn coming for that family, we will test him for the Glasman thrombosthenia. 98% of them, they are product of consanguineous marriage. And 86%, they have family history of Glasman thrombosthenia. And 60% of them, they have another sibling whom he has Glasman thrombosthenia. 25 families, they have 2 to 5 children with Glasman thrombosthenia. When we report this family pedigree, probably 6 years ago, we thought this is the largest family of Glasman thrombosthenia in the world. When we are preparing for this publication, there was a family with 40 patients of Glasman thrombosthenia, and we are studying that for publication. The presentation or the bleeding that is happening in those patients, as all platelet disorders, it is mucocutaneous type of bleeding, gum bleeding, epistaxis, process, and of course menorrhagia in ladies, which I'll come back again. In our cities, we have reported gastrointestinal bleeding, angiodysplasia in 8 cases, hemarthrosis in 4 cases, intracranial hemorrhage in 2 cases. 80% of our patients, they are type 1, and 3% of them, they are type 2, and 18%, they are not in record. We do not know which type of them, but I know that maybe 2 or 3 patients, they are variant, and we have diagnosed them only through molecular genetic. When we talk about the course of the disease, we are talking about how we control the bleeding. So the mild one, they can control the bleeding at home with the local management, and the severe one, when they need to be admitted, they need to be admitted to BICU, or they have significant drop in hemoglobin, or they need to spend more time, more than 3 days in the hospital. And at that regard, that almost 50% of our patients, they run mild course. And again, more than half of them, they have less frequent bleeding, which is less than once per year. And those whom they have severe, which is more than 1 episode of bleeding per month, 17%. And 1/3 of them, they have about 6 bleeding per year. This is the molecular sequencing for our patient, and this is part of the a study where Dr. Aweda has conducted, and we have the 14 mutation in ITG A2B gene in 65 GT patient, and in ITG B3 3 mutation in 35 patient. Iron deficiency anemia is very common among our patients where 2/3 of them they have iron deficiency anemia. Fortunately, they respond to iron therapy, where oral iron therapy, where we recommend IV nowadays. Menorrhagia is a common problem among Glanzmann thrombocythemia, and the first patient where she had severe one, and as the protocol called in 2009 or 10, to cease the menstruation and to start hormonal therapy. 6 months later, she came back with, again, heavy menstruation. And then simply, she is a girl, cannot be without menstruation. Nobody going to marry her. In 2022, I have presented something as such in ISTH. So our friend in Iran, Pakistan, in India, they have showed the same issue among their patients with Glanzmann or other bleeding disorder. So at that time, we have developed something in midway. We gave them hormonal therapy, and we allow menstruation to happen, where we control it with tranexamic acid, 7A, and we restart the protocol. Those patients whom they have subsequent recycle, which is heavy, so they exit the protocol and go for persistent hormonal therapy. Later on in 2017, we have found many patients, they have menstruation which is normal or mild menorrhagia, where can control without hormonal therapy. So we allow those patients to go into an observational period. Then we choose whether they need to go into a protocol or not. 45 ladies and young ladies, they have menstruation. 22, they were in 2014. 6 of them, they have exited the protocol due to heavy menstruation, and 9 of them, they have continued. The 2014, several of them transferred to 2017 protocol, and 12 patients, they continued in 2017 protocol. So the idea that all Glanzmann thrombocythemia patients, they need to be on hormonal therapy to cease their menstruation is not true anymore. There is 10 patients, they are running Glanzmann, menorrhagia, without any treatment, without hormonal therapy, and life is smooth. 10 ladies, they get pregnant, they reproduce 28 pregnancies, and we have this presented as a poster at last ASH. This is the poster. And those 28, they have reproduced a significant number of babies. They have miscarriages, which is higher than the normal population. Astonishing that the parity is 1:6 and the gravity 1:7. Among a Glanzmann patient, this is high. Postpartum hemorrhage is common in 2/3 of our patients. They have postpartum hemorrhage, and we have found in another study that there was no correlation between what we are doing pre-delivery, I'm talking about prophylaxis, or postpartum hemorrhage. This is another study going to be published probably next or month or after. We have tried prophylaxis for those patients whom they have frequent bleeding. So we allow regeneration of the mucosa, particularly those whom they have epistaxis. So we keep them in 7A, 270 mic per kg 3 times a week, and usually it is given at home for 3 to 6 months. And we have found that it was very successful in all the 11 patients we have studied. And we thought about that we are using more amount of 7A, but when we have studied that, statistically, it showed that there was no significance between when they are on prophylaxis or the 6 months before that, so it is the same. Alloimmunization, 11 patients, they have antiplatelet antibodies. 4 of them, they were platelet refractoriness. And when we compare that to the other publication, we found our data, it is very low among the Glanzmann thrombocythemia. We cannot explain it very well, except that either we are not looking for the antibodies very well, or we are not using platelet as upfront medication, and we are using 7A as upfront medication since 2009 or 2010. Maybe this play a role to have low alloimmunization among our patients. Genotype, phenotype correlation, previously we thought that there was no correlation, and maybe that because we don't have enough number. Now, when we compare 3 type, which is the largest number of patients in those 3 mutations, we have found some mutations, they have more the severe course or more frequent bleeding compared to the other mutation, so that the correlation is statistically significant among those patients. In conclusion, Glanzmann thrombocythemia is the commonest bleeding disorder in Medina population compared to the others, including the von Willebrand and hemophilia. There is a high rate of menorrhagia, but can be controlled with other modalities except for ceasing the menstruation for those patients. Iron deficiency anemia, particularly in children and ladies, is very common and need to be taken care of and treated promptly. High rate of consanguinity may explain the high rate of the Glanzmann thrombocythemia among our population. And thank you.